Bismillahirrahmanirrahim. So today I'm going to talk about the approach to the pleural effusion. So how would you approach a patient with pleural effusion? Pleural effusion means the accumulation of the fluid in the pleural space. So the first thing you should ask from yourself is the pleural effusion unilateral or bilateral? Is the pleural effusion unilateral or bilateral? If it is unilateral, then most probably it is exudative. Mostly it is exudative. I'm not saying that in 100% of the cases it is exudative, but if you see a patient with pleural effusion and that is unilateral, either right side or the left side, then you should think of the causes that causes exudative effusion. And what are the two main causes that causes exudative effusion? Infection and cancer. Infection and cancer. And if you see the pleural effusion that is bilateral, so you should think of transudative. You should think of transudative causes. And the transudative causes, we mean liver, point number one, liver. CLD, a patient with CLD present with bilateral pleural effusion. Heart, a patient with CCF or acute LVF present with bilateral pleural effusion along with pulmonary edema if it is more decompensated CCF. Kidneys, in renal failure, a patient present with bilateral pleural effusion and the cause is transudative. In GIT, if there is malabsorption or malnutrition, there is decreased albumin. That decreased albumin is because of either the loss of amino acids or protein. If there is protein malabsorption, so there is no albumin in the blood at all. So there is no albumin in the blood at all. Malnutrition or malnourishment. So these four things can cause transudative effusion, usually bilateral. And how to treat them? Treat the cause. And if the cause is not treatable, give diuretics. Give diuretics. The second thing we should ask from yourself is it exudative or the transudative? If you do not get the answer from these, a patient is having bilateral effusion, liver, heart, kidneys, and GI is normal. There is no abnormality detected. So what is the next step? You apply the lights criteria. You apply the lights criteria. That is, you do investigation, you take out the fluid and do investigation on that fluid. What are the two investigations? The protein and the LDH. Protein and LDH. So you take the pleural fluid protein divided by serum protein. If that is more than 0.5, or the pleural fluid LDH and the serum LDH, if that is more than 0.6, or the LDH in the pleural fluid is equal to or more than 2/3 of the upper limit of the serum LDH. Now we have to understand this point. If any one of this is positive, if either this is positive, this is positive, this is positive, if any one is positive, the fluid is exudative. The fluid is exudative. It does not mean that you have to fulfill all the criteria for the fluid to label as exudative. Even if a single thing is possible in this, the fluid is exudative. But we have to take the upper limit of LDH. Let's suppose we are having a serum LDH of 240. We have the serum LDH of 240, but the range is 230 to 290. So you have to take this, the upper limit of the LDH of the serum. So what do? You take the serum LDH, take the 2/3 of that LDH, and whatever answer comes, you compare that with the fluid LDH. If that is equal to or more than the pleural fluid LDH, then this is exudative, then this is exudative. Now what are the causes of transudative effusion? We have studied that: liver, heart, kidneys, and GIT. And what are the causes of the exudative pleural effusion? So the two most common causes are the infection, the cancer. Infection, we are having pneumonia, we are having the TB. Pneumonia, TB. And in the cancer, we are having the primary lung cancers and the secondary lung cancer. That is the metastasis. Metastasis can also cause this exudative effusion. What are the other causes of exudative effusion? What are the other causes of exudative effusion? So we are having pancreatitis. Pancreatitis can cause exudative effusion. Pancreatitis can cause exudative effusion. And use of diuretics. Use of diuretics, because diuretics excrete the fluid more as compared to the proteins. So you are having exudative effusion in case of excessive use of diuretics. That can also cause exudative effusion. Uremia, you can expect the exudative effusion. You can expect the exudative effusion. Aortic rupture, you can expect the unilateral as well as exudative effusion. So you have to keep those things in mind. And also inflammatory diseases like SLE, rheumatoid arthritis, SLE, rheumatoid arthritis, these are causing the exudative effusion. These are causing the exudative effusion. And what are the conditions in which there is bilateral exudative effusion? Exudative effusion is usually unilateral. Bilateral exudative effusion can be seen in case of CA, cancer, ovarian cancer, that is called Meeks syndrome, in which there is a ovarian CA causing massive ascites and causing bilateral effusion. So you did a routine examination of pleural fluid, and that showed exudative lymphocytic effusion. Exudative lymphocytic effusion. What is the diagnosis? What is the diagnosis? Point number 1, workup for TB. What workup for TB? Gene expert, FB, gene expert, sputum studies, ESR, Manto test. If TB workup is negative, what is the best next step? Malignancy. And what is the best next step? Plural biopsy. For the pleural biopsy, we are having two methods. One is, of course, malignancy can give you exudative and lymphocytic picture. Pleural biopsy can be done by two procedures. One is the blind procedure through Abraham needle. You don't know, but you insert the needle and take a chunk of the pleura, and you do not know from where you have taken the biopsy. The current recommendations are, that is pleuroscopy. You enter an endoscope and you actually visualize the pleura and you detect the pathology. Where is the pathology? And you take a specified chunk from specific area in which you have high suspicion. So this is superior as compared to the blind procedure, because it allows the direct visualization of pathology. So that was exudative lymphocytic effusion. Now if you are having this picture, exudative neutrophilic effusion, what is the best thing that comes into your mind? Bacterial infection on the top.